We are the Association for Child and Adolescent Mental Health, or ACAM for short.
Hello, welcome to the Papers podcast series for the Association for Child and Adolescent Mental Health, or ACAM for short. I'm Jo Carlo, a freelance journalist with a specialism in psychology. In this series, we speak to authors of papers published in one of ACAM's 3 journals. These are the Journal of Child Psychology and Psychiatry, commonly known as JCPP, the Child and Adolescent Mental Health, known as CAM, and JCPP Advances. Today I'm interviewing postdoctoral early career researcher Lizél-Antoinette Bertie and Professor Jennifer Hudson, both of the School of Psychology, University of New South Wales, Sydney, Australia, and the Black Dog Institute at the University of New South Wales. The Black Dog Institute investigates mental health across the lifespan. Lizél and Jen are authors of the paper Editorial Perspective, Extending IPDMA Methodology to Drive Treatment Personalisation in Child Mental Health, recently published in the JCPP. This paper will be the focus of today's podcast. If you're a fan of our Papers podcast series, please subscribe on your preferred streaming platform. Let us know how we did with a rating or review, and do share with friends and colleagues. All listeners to this, and indeed any of the ACAM podcasts, are eligible for a free CPD certificate. Do please visit acamlearn.org for details of this, together with information on how you can access hundreds of hours of free talks, lectures, interviews, all of which you can also get free CPD certificates for. The URL is www.acamhlearn.org. Lizél and Jen, thank you for joining me. Can you start with an introduction about who you are and what you do?
Thank you, Jo. My name is Lizél, and I'm a postdoctoral fellow in the Child Mental Health at Black Dog Institute and University of New South Wales. And my research focuses on improving personalised mental health, but in a data-driven way.
I'm Jenny Hudson. Thanks so much for having us on, Jo. I'm the head of the Child Mental Health Research at Black Dog Institute, which is in the Faculty of Medicine at UNSW, and also part of School of Psychology. So my research that I do alongside of Lizél really focuses on trying to improve mental health outcomes for kids and families in the community, and conduct a lot of clinical trials. We develop new treatments, assessments, preventions, and early interventions, with really a focus on school-age children and adolescents with anxiety disorders.
Thank you very much. So today we are focusing on your JCPP editorial perspective, extending IPDMA methodology to drive treatment, personalisation in child mental health. Before we go into the detail, can you define and briefly summarise how individual patient data meta-analysis, IPDMA, works?
IPDMA is really a specific type of a literature review process, really a specific type of meta-analysis. So typically a meta-analysis review provides researchers, clinicians, as well as the broader community, really an opportunity to synthesize a heap of research on a specific research question. And the idea is that it's a systematic process that researchers scour the literature using strict inclusion-exclusion criteria. And the idea, we want to arrive at a set of studies to synthesize all the findings together. So researchers who conduct a meta-analysis, the idea is then you extract that data from that selected group of published papers. And what we extract from that data is means and standard deviations, so that we can arrive at effect sizes. And then we pull that information together in a way that can help us really understand what should be closer to a true effect, rather than being reliant on a particular sample or a study. But an IPDMA differs really at the point of data extraction. Instead of extracting study level data, so means and standard deviation from published papers, the idea of an IPDMA is that you ask the study authors to provide de-identified data from each participant. And then, so instead of kind of pooling the average of average effects, you actually are pooling the individual data. So it really allows for a much more nuanced approach to data, kind of allows us to take more than just an average effect across all participants, and giving us a larger sample size. We then have the capacity really to do a much deeper dive into the data set and answer much more useful questions about specific groups and specific treatments.
I'm just wondering then, can you talk through the limitations of randomised control trials, systematic reviews and conventional meta-analysis in terms of answering research questions about what works for an individual?
typically the intervention trials focus on the average outcomes of treated children and adolescents using indexes like remission or response. And that's really important when trying to understand how effective the treatment is. And also, of course, which factors are associated then with better or poorer outcomes. A systematic review will then combine the information from randomized controlled trials and draw conclusions based on their findings. And a conventional meta-analysis, as Jen was saying, will then synthesize those study level effects. But none of these methodologies give us more information or explain why children respond differently to treatment.
So I suppose individual clinical trials, they're typically designed to have the power to detect group differences over time. So clinical trials are really expensive. They take a lot of time. They're really labour intensive, and it's really hard work, I suppose, achieving the sample size that are required. But the clinical trials really help us to answer questions like, does treatment A work better than treatment B? But it's for all children, so averages without the effects. So it's very much a one-size-fits-all approach. And of course, as researchers, after we've conducted these clinical trials that help us to answer these specific questions about treatment efficacy, we often want to do more of a deeper dive into answering other questions, but we do post hoc explorations really, because the studies are really only ever designed to detect that main effect of, does treatment A work better than treatment B? We will go about asking questions like, well, what about the effects of this treatment for younger kids in the sample? Or what about the effects of the intervention for families from non-English speaking backgrounds? But these questions really, they're the useful questions that we want to be able to know is the answer to as clinicians, because we do see, a very diverse group of children and families. But the way that we approach that typically in clinical trials, it's always exploratory, because we never really have the power to answer that question in detail. Particularly if you've got, in one clinical trial, you only have a handful of, say, 6 to 8 year old children, or, a handful of people from non-English speaking backgrounds. So approach really is underpowered and has produced really a mess in trying to answer what works for whom. Each study finds something different. When one subgroup effect is found, it's hardly ever replicated in the next study. And so we just kind of have this very, very difficult set of findings to understand.
Let's go into the detail of the paper itself. So can you give us a brief overview, telling us what you looked at and why?
Well, we've been on this quest, like a lot of mental health researchers, to really find the holy grail of personalised treatment, of what treatment by whom is most effective for an individual with a specific problem and under what sort of circumstances. This is kind of the question that we've been trying to answer for a long time in psychotherapy research and mental health research. And this kind of personalised approach has been really successful in cancer treatment, but really in mental health research, we have not yet found this elusive holy grail. So this, I suppose, could be for two reasons. It could be one, that this holy grail that we're in search of doesn't exist, despite our desire for trying to personalise mental health care. It could be actually that modifying treatment components based on different aspects of a child's presentation will in fact not lead to better outcomes. So in answer to the what works for whom question is that most things work for everyone. Many of the meta-analyses of psychotherapy have pointed to this quite unpopular answer. And I'm not really ready to swallow that bitter pill, because the second reason why we might not have clear information about what works best for whom is that we haven't really tested this question with rigorous methods and data. And to design a study to answer these questions rigorously would really be a couple of lifetimes of work if we were to embark on that study as fully funded if we started today. So instead of doing that, what we have done in this project that we've published on is actually pooling data from existing data sets. So we've invested a lot of time in a lot of clinical trials in child mental health, and a lot of families have provided data contributing to science. So we want to maximise the use of these data. So we conducted a systematic review of the literature and identified studies for us to include using that systematic approach that we were talking about. We've established a procedure, we've got data sharing agreements from authors, and requested that data and we're trying to synthesize it. We're at that point, and I'll get Lizél to talk a little bit more about that in terms of, where we're up to. But that's what we've been talking about in this particular paper, in that process of bringing together this living systematic review or a repository, a topic-based repository.
Lizél, do you want to add anything to that before we go into the details of the findings?
Just a little update on where we are at. So we've conducted the review, and to date, we've identified 350 studies that meet our criteria. And of course, we know not all of those will be accessible. They range from, I guess, about 20 years spectrum. So, some of them might not be available to us. There might be some limitations to the sharing of data from some of the authors, but we have collected to date 91 studies. And we're in the process of harmonizing the data for that. It equates to around 7,000 participants in this pooled data set. So that's a huge number, making this one of the largest combined data sets in the world. And we're very excited to get to this point, where we have something to show for the hard work that we've put in over the years.
And my understanding is you chose to focus on anxiety disorders in the context of youth. Why specifically anxiety disorders?
Anxiety disorders in kids and teens are still overlooked a great deal, despite the significant contribution they make to global burden of disease. It's still a disorder that is not really focused on a great deal in research. And there's popular belief really that mental health problems don't really start until adolescence or adulthood. So this kind of childhood, early adolescence period is often, really overlooked. But we know that when you look at the development of mental health problems, that particularly for anxiety disorders, they start in childhood, not in adolescence or adulthood. So we really want to be investing in improving interventions for children who present with common mental health disorders like anxiety, and delivering interventions when they first need it, not 20, 30 years later. So we think this area of anxiety disorders, because it's overlooked, deserves more attention. And also, we've been working with this team of researchers for a really long time now. We've been meeting at conferences, international conferences, and it's a really nice group of people. We work with kids, we're fun and friendly, and mostly, on the whole, we are quite collaborative as a cohort, and a strong cohort of female researchers as well, I think, who really understand that it takes a village to get this kind of work done. And as we work together, we can answer more meaningful questions together rather than in our own silos. So there is quite a really nice collaborative spirit that we've kind of built together in the child anxiety field. And this has really helped to set the platform for this work to be done, and for it to be done well, because people are willing to provide their data. We've got a process, and we've got that trust built up with our collaborators as well. And there's this goal that we want to be able to deliver effective personalised care for kids when their anxiety disorders commence, and offer something that's tailored to their needs.
Thank you. What key points would you like to highlight from your editorial?
I think one of the first points, although this is not the only way to establish a data repository, we wanted to follow a rigorous methodology, especially if you think about what Jen said earlier. If indeed personalisation rests on the methods we use and the approaches we take, we wanted it to be as rigorous as possible. So we followed this specific approach that we mentioned in the article. It also ensures clear and transparent reporting, which is something that can be followed through the whole project, which is also really important in the field. It also facilitates a specific data structure, which is important, not only retrospectively, pooling the data in a certain way and ensuring that there's a standard structure for it, but also prospectively. We're hoping that researchers in the future will design their studies based on this structure that we've created, which will just make it that much easier for us to accommodate into this platform going forward.
I think the point that I wanted to highlight was how much of a team effort this has been. So I think, so far, we think it's been about 7 years that we've been working together on this project. Professor Micah Nauta from the University of Groningen and I started working together 7 years ago, unfunded, to try and establish this piece of work. And we both now have preliminary funding, and this has really helped us to bring along more team members and to really fast track the process. And we've got an incredible team. Lizél-'s been working with us for almost the whole time, I think. And we've got other team members who are authors on the paper, Wendy Chen and Bas Koeman. And that's really helped to establish this team that's enabled this work to be done. Lizél joined the team 4 years ago, and she's just submitted a PhD thesis on this PADI project. And Lizél's really been the passion and drive behind this piece of work. She's taken the project to a whole new level, and I'm so grateful to have had the opportunity to work with her on this, first as a grad student and now as a postdoc researcher. So it's been a really exciting, fun team effort to work together on.
Thanks, Jane. It has been a real joy to be part of the team.
Lizél, you touched on the point that you would like other researchers to work in this way, to use this design. Is there any further message that you have for researchers that they could take from your editorial perspective?
Yes, definitely. In the pipeline, we have a number of interesting ideas to facilitate this transformation in our study design. And we are working on specific items that belong to this project, codebook, how to code our variables, or specific methodologies that we will incorporate. They will be available to researchers to read as a resource and to use in their planning and execution of their studies.
Excellent. Just going into some of the details in the paper, well, you state in the paper that although treatments are frequently personalised in clinical practice, there is a lack of science to guide clinicians in their adaptation of treatments for clients with complex or varied presentations. How do you envisage the approach outlined in your paper moving the field towards evidence-based personalised mental health care? So in other words, how might your viewpoint be translated into practice?
Yeah, it's a really good question because we really desperately need science to drive personalised care. Some of our efforts really can be translated into practice already. We can now predict which children are less likely to respond to standard treatments based on the kind of preliminary work we've done together building this data set and other collaborative projects. So this is helpful for clinicians to be able to say, how likely a particular approach will work with their client population. We'll also now, with the development and establishment of PADI, be able to test out some of these early predictions that we've been able to make from the data so far and potentially discover new predictors when PADI is fully operational. But at the moment, this is the kind of point that we're stuck. We can't say what else a clinician could try. So we have evidence about which children are less likely to respond to treatments, but we can't say what else a clinician should test out. We can't say what would work better for a child who's at risk of having suboptimal outcomes following standard treatment. So despite our best efforts, we really haven't moved very far as a field in psychiatry and psychology in this regard. We've spent years developing new innovative treatments that we think might work better, but we still roughly get the same average effects.
From the research, which children are less likely to respond to treatment?
So we know that children who present with more severe anxiety, higher levels of social anxiety and low mood, and also who have parents with psychopathology themselves, less likely to respond to standard CBT. That's the bit that we can say, yes, we can tell you which children are going to respond suboptimally, but we can't say at this point what else to do. It would be great for the science to catch up. And this is what we're trying to do with PADI, is to build this data set where we're bringing together, harmonizing all of these data points so that we can answer those questions in a better way with larger data sets. So at the moment, clinicians really do their own personalising in treatment. They develop a treatment plan that's based on a formulation, and this might be based on their training or their clinical experience or their beliefs. And, they might do a bit of this treatment, and if that doesn't work, they'll try something else, they'll adjust it. But really, these adjustments are theoretical and not empirical. So our goal is with PADI is to be able to keep adding to this sample to make it more diverse, building up the subgroups within the population so we can really use this to be in a position to advise a clinician the best treatment options for their client. So if you want to think about an example, maybe a clinician who's been referred a 10-year-old girl, she's got severe levels of social anxiety, comorbid general anxiety, and comorbid low mood. Perhaps both of her parents have high levels of anxiety and they come from a low socioeconomic urban demographic. Maybe mum has past trauma. A young girl might be refusing school, not responding to previous treatment that she's been getting or support at school. Now, if you kind of consider another referral, let's just say a 16-year-old boy with panic disorder and specific phobia of heights, he's had no previous treatment. At the moment, what our data, what the guidelines recommend is that the treatment for both of these cases would be identical, CBT. And then if that doesn't work, try antidepressant medication. And that's about as personalised as we can get based on the average of averages that clinical trials and meta-analyses have produced so far. So what we're trying to do is be able to provide much more nuanced information that when a clinician does have a referral for a child that has much more unique or diverse backgrounds, they can be more prescribed and more personalised in their care. And that can be driven by data rather than being driven by trial and error.
That's really helpful. It really brings it home, really, the limitations. A few times now you've mentioned PADI, which stands for the Platform for Anxiety Disorder Data in Youth. In the paper, you discussed the need for the formation of a topic-based data repository. Can you explain why this is important and illustrate how this has worked with the development of PADI?
Yes, so firstly, researchers, we've known for a long time that our typical analyses have not been sufficiently powered to detect these moderators, which are the factors that Jen has just described so well. These factors that tell us which treatment will be better for the 10-year-old girl versus the 16-year-old boy will lay the foundation for us for personalizing treatment. So we've known that this has been a problem for a long time. And we've had some individual IPDMA studies that have been conducted, resulting in really great information and useful clinical guidance, but it's never been used subsequent to that once-off exercise. And we just thought that's such a waste of fantastic resources. So building PADI has been really important for us to overcome that limitation. It also typically for an IPDMA to be conducted, it takes a huge amount of effort. As Jen has also mentioned, literally years in the making. Communication, resources from a time and skill perspective, just so we can use that data again. So we began to build PADI, collect the data on childhood anxiety exclusively, which makes it a topic-based data repository, so that we could have those adequate sample sizes we need. And of course, the statistical power to answer existing and newer research questions.
For popular topics, having this a topic-based repository, it really helps us to answer bigger questions. Researchers tend to have specific interests. I want to answer this particular question, and so these will be my inclusion-exclusion criteria, and we may you want to include certain studies, but there's a lot of overlap perhaps between what I'm interested in and what other researchers might be interested in, or what Lizél might be interested in. And as Lizél was saying, so much effort goes into building each individual meta-analysis or each individual IPDMA that if we can kind of share that load, it reduces the overall workload, and you can reduce burnout in researchers as well, makes each clinical trial funder dollar go further as well, and also provide opportunities for other researchers within a particular topic to be able to answer other questions that they might be interested in.
In the paper, you state that the formation of a data repository contains ethical risks and logistical challenges. Can you elaborate on these and talk through how such challenges can be met?
Yes, so what we have learned from the literature, as well as from a couple of lived experience situations, is that the greatest concern is anonymity and confidentiality when it comes to participant data. So what we've done in PADI is we've, of course, made a blanket statement and rule for participation is to only share de-identified data We also, as Jen mentioned earlier, have a data share agreement in place. So that will govern all kind of communication between the researcher and the author and our team. And then for researchers, on the other hand, they might be faced with not knowing whether they have an ethical obligation to share or not share their clients' data. And that might differ from country to country, but we have established a procedure around that as well in PADI that we can share with the researchers to guide them in the sharing of the data.
So, yeah, there are a number of logistical challenges as well to coordinating this large amount of data. And we need to, once we've identified the studies, we need to ask authors to contribute their data. And for a lot of researchers, that's a big ask. Perhaps researchers are really busy. Maybe they conducted the research 20 years ago and it's sitting on a hard drive. We've had people saying, oh, I've moved on several universities. It's now sitting in a hard drive in a computer in the bottom of a hospital, or that kind of reluctance to want to actually share their data set, and that maybe everyone else is going to have a look at how they construct their data sets. And but it's a lot of chasing of researchers as well. So there's the time factor that researchers have in actually being able to get the data in a point that they can share it with us amongst their already overburdened busy schedules. We've got to do a lot of chasing as well, reminding people. I have the same experience being on the other end of it when other people are asking for my data for an IPDMA or a meta-analysis. It's like, oh, every time I see their name in my email, I have this sense of guilt. I haven't got back to them yet. And, I kind of get that sense that we're building that in our within our collaborators, that every time they see our names, they have this fear and guilt that they haven't sent the data on time. But, it has been a lot of time chasing and following up. So this is why it's great to use it rather than just for a one-off IPDMA, which is often the way it happens with IPDMAs. You do all this work and then it's just one-off. There is this expectation that IPDMAs should be shared, and that most IPDMAs, people will be looking at PADI and saying, well, isn't that normal for IPDMAs that you're meant to make the data available? But I suppose what we've done differently is that we've set up the process right from the beginning that the data are going to be shared and going to be made as a resource for everybody who's contributing. Also that they'll be able to use it, and that we have those procedures for authors for sharing and the process of updating it as well. So it's not just a one-off.
Lizél and Jen, is there anything else that you would like to highlight from the paper, or any further recommendations that emerge from it?
We really need to be more collaborative to advance the field, not just in child anxiety, but across mental health space, to be able to advance the field of personalised mental health care, to really answer this question about whether or not we can build the science to personalise care, or is it just that most treatments work for everybody? And to be able to answer that question, we've all been trying to answer it for a really long time, but in silos. And, I think the idea of bringing this together as a collaboration, I think is a really good example of being able to advance the field by being more than just the sum of our individual trials.
Yeah, and I think just building on that, another part that is a highlight for me has been it's been very satisfying to interact with all the international collaborators. So that sense of collaboration has really grown over the last 4 or 5 years, and it's a network that's ever expanding, and that's just really been such a satisfying part of the project as well. Getting to know each other, connecting on a different level, and collecting data from 12, 14 different countries has just been fantastic. And of course, we're hoping to expand that.
Brilliant. Are you planning any follow-up research, or is there anything else in the pipeline that either of you would like to share with us?
Well, I have given you an update on where we are at. So we've completed our 3rd systematic review, and we'll continue doing this. So as resources and time allow. For now, we still have our work cut out for us. We're just harmonizing our first batch of studies, and I think we have in our team a number of studies that are waiting for the data to be harmonized and situated on our platform. We have a system in place to make the data available to researchers, and there will be a procedure involved, of course, for them to access the data. But it's really exciting just to think about what Paddy has made possible for researchers across the globe.
Yeah, we're about to present this work to you at a national conference in a couple of weeks and an international conference in the US. And also having some collaborative meetings with our contributors as well, people who've contributed the data, and giving them an update because it has been, a long road, and they've shared their data with us and trusted us with their data. So it's good to be able to provide some updates to them, about where we're at and what we're hoping to achieve.
Finally, Lizél and Jen, what are your take-home messages for our listeners?
We hope that our listeners are as excited as we are about the opportunities that Paddy is creating. And for me, I am excited about pursuing a more data-driven approach, which is really the focus of my research. Every time we have this conversation, I think of a quote in a paper that clinician said, "We have loads of ingredients, but we have no recipes." That has stuck with me, and I think that's built my research around that. I would like to provide clinicians with the recipes in a data-driven way to help them provide care for the children who need it most.
Jen?
I think one of the take-home messages is around the model of data sharing that we have created here. Really show others how you can achieve more through collaboration and bigger data, and how this can be done with sensitive data, with child data, with mental health data, and doing it in a way really that allows others to benefit from the hard work that goes into a clinical trial and an IPDMA. And in particular, I think it's going to be a real benefit for early career researchers, and it'll be a resource in the future. We can set it up in a way that benefits all. So another take-home message is really around the need for the science behind personalised mental health care. From the research so far, which clients might have less optimal outcomes, but at the moment we can't tell you what else you can try. We can't tell clinicians what else to try. So perhaps for clinicians as well, in the meantime, taking a science-based approach to their own personalised treatment that they provide for their clients, measuring and tracking their decisions, and understanding their own decisions around personalised care, and in a way building their own science behind it while we wait to catch up with the science to support you in those decisions. Another thing I just wanted to say too is a big thank you to all the researchers who've been patient with us as we build this data set slowly and entrusting their data to us. And it's been a real privilege to work on this project.
Excellent. Thank you ever so much, Lizél and Jen. For more details on Lizél-Antoinette Bertie and Professor Jennifer Hudson, please visit the ACAM website, www.acam.org, and Twitter @ACAM. ACAM is spelled ACAMH. And don't forget to follow us on your preferred streaming platform. Let us know if you enjoyed the podcast with a rating or review, and do share with friends and colleagues.